Okay, by bringing forth professionals from the respective fields to be able to share with us important things that will enable us collectively achieve. Okay. So let me just run us through PSI, a brief about PSI before we highlight the program of events. So this is our logo, and you can actually see pharmacy profession clearly represented there in our logo. So we just have some quick announcements just for people to know and to have their consent. We are recording this webinar. We are recording so that we'll be able to put it in our website. We have a website, and during the course of this program, I'm going to share our website for people to be able to copy, to be able to visit. Down there, when you go, you're going to see a lot of our activities, a lot of our documents, a lot of things that we've done in the past. And in case you want to ask a question, you can please use the chat box. And if you prefer to talk, you can actually do that by signifying that by raising your hand using one of the emojis chat. And as always, we are for continuous quality improvement in PSI. So we welcome feedbacks. We want to always improve. So if you have any comment for us, please do not hesitate to reach out to us through our website, through our email, pharmscholarsinitiative@gmail.com. I'm also going to share that with you in a while through the chat box. So just to have a little overview of what PSI stands for, the major thing we do is mentoring. So PSI is a mentorship network for pharmacists with a keen interest in research and career development. So key things we do in PSI is to mentor ourselves, to motivate ourselves, and to bring younger pharmacists to be able to have skills in research, and not only that, we encourage each other to have the necessary experience, necessary knowledge to be able to advance our careers. PSI was founded in 2017, so that is why today we are marking the anniversary. It was founded in December. Back then, it started with just an idea by the founder, the person of Dr. Ibrahim Jato, who is now our president, and he had 3 other members who are co-founders. We call them the board of trustees. And today, I can actually say we are proud to have well over 40 members in PSI, from 1 to 4, and today we are up to 40. And PSI was registered, is currently registered with the Corporate Affairs Commission of Nigeria.
So we have some network glitches.
Yeah, it seems to be frozen.
What do we do?
Yeah, I think we can just maybe take over. Yeah, so we can let me continue.
I think he's joining. I think he think we are listening.
Listen to him.
But he's muted, actually.
Yeah, he's back.
So he needs to unmute himself and, if possible, stop his video.
Hello?
Yes, we can hear you, sir.
Okay, am I loud enough now?
Yes.
Having a bit of a network challenge. Okay, I think you got me up to this level where I was given an overview of PSI. And I was saying it was founded in December 2017, and it started with just 1 member, and who is the founder of PSI, in person of pharmacist Ibrahim Jato, PhD, and had 3 other members who actually came together to be our co-founders, and we call them the board of trustees. And we are duly registered with the Corporate Affairs Commission of Nigeria. Back then, we started as young pharmacy scholars, but we realized we needed to change because that name cannot actually stay forever, as we are not always going to stay for young forever also. So we changed to Pharmacy Scholars Initiative to reflect fully what will actually stand time. And currently we have up to 40 members, well over 40, maybe 41. And these members are actually Nigerians, but residing in Nigeria and working in Nigeria, and a lot of others also studying and working in other continents. We have presence in Australia, we have presence in the US, we have presence in Asia, Malaysia specifically, and we also have presence in other parts of Europe, the UK, and Turkey. So we are actually quite a global organization. So just a rundown of the objectives of PSI. One of our objectives is to assist young researchers in the conceptualization of research ideas, designing research, conducting research, or reporting research. And I can tell you we have had a lot of publications through PSI. Last year, the main theme of the purpose of our anniversary actually was to highlight our achievements. So when you have time to visit our website, you'll be able to see a compendium of PSI research or PSI inspired research that is actually placed there. So it's important that you take your time to look into our website. And one other objective that we have is to support young researchers on scientific writing skills for proposal, thesis, and manuscript. Most of us joined at a point where we were doing our masters, maybe at the time when we needed to do thesis, and we, through referral, through actually personal engagement with people in PSI, we were able to join, and today here we are with a number of publications, courtesy to PSI. And another objective that we have is to share and discuss educational resources. We have weekly engagements, weekly lectures, weekly webinars. Sometimes we do through WhatsApp, through virtual means like Zoom, and we educate and enlighten each other, and we share resources and also guide each other on career development. We share scholarships and a lot of other educational advancement programs. So that is what we do at PSI. So as today marks the 5th anniversary of PSI, we have with us distinguished personalities. Just to state, this activity today is being chaired by Professor Ahmed Chimera, our father, our mentor, our guardian, who has always stood with PSI, and he's currently the chairman of Pharmacy Council of Nigeria, and was one time the registrar of the same Pharmacy Council of Nigeria. And he's a professor of pharmacy practice, and he has made a lot of contribution in pharmacy practice. What pharmacy is today in Nigeria, there's no way that can happen without you mentioning our father, our mentor, Professor Ahmed Chimora. Yeah, welcome, sir. So let me share with us the program of events so that we'll be able to see. So this is what we're going to run through today. And we are very mindful of time. We know today by 4 p.m. Nigeria time, we are going to have the World Cup. So we intend as much as possible to minimize, to maximize use of our time, and we should be able to finish before 4. So we'll be having the welcome address by Ibrahim Jatau. Then importantly, we have 2 lectures, one to be delivered by Dr. Abubakar Danraka, who is going to talk on promoting impactful pharmaceutical research for national development. and a second lecture by Timothy Kujiyat on managing long-term conditions as an independent prescriber in the UK. So without much waste of time, I would like to invite Dr. Ibrahim Jato, President PSI, to give us his welcome address. Dr. Jato, over to you.
All right, thank you so much, Dr. Abubakar Isa Musa. Let me share my slides.
Okay, let me stop.
All right.
Ibrahim, are you there?
Yes, sir.
Okay.
Good day, everyone. As introduced, my name is Ibrahim Jato Abubakar, and I'm the president of Pharmacy Scholars Initiative. I would like to use this opportunity to welcome everyone to our 5th anniversary celebration webinar, most especially our father, Professor A.T. Mora, MNI, and our guest speakers, Dr. Abubakar Danraka, who has been with us from inception to date. He has been part of our webinars and other programs. And also my colleague, Pharm, Timothy Akau, who is my classmate back in Abu Zaria. So today has been a very wonderful and very happy moment for every one of us at PSI, being part of the mentoring program, promoting research activities among upcoming researchers, especially in pharmacy. So the whole idea of PSI is about mentoring. And mentoring has been a critical component of every success in all aspects of our lives, being a pharmacist or any other professional. So at PSI, we recognize the value of mentoring as a key element of our vision toward improving our members for professional development and any other career progression. So from inception in December 2017 to date, that is December 18, that's our 5 years, mentoring has been a driver for the creation and the growth of PSI members. So throughout this period, what we have been doing on daily basis is all about mentoring, how we can support our members to be better in all the aspects and ramification, especially in terms of research. So throughout this year, throughout these 5 years, we are able to do these activities. So over the last 5 years, PSI has constantly maintained its existence through the following mentoring activities. So throughout 5 years, we're able to do our activities on daily basis, on weekly basis, on quarterly basis, and annually. That's what we are experiencing today. So on daily basis, we always routine engagement with members through discussion, posting questions and answers, and then sharing research opportunities such as PhD, postdoc, and like other self-development certification or trainings. We also had weekly webinars where we invite members of our members to present on any particular topic that is relevant to us, and that could be very, very beneficial towards research or any other career development. So in every week, in these 52 weeks of the year, we had a lecture every week. I think we recorded over 90% success. It's only some few times that we couldn't have because of some reason beyond our control. And at every quarter, we normally have webinar where we invited external experts of international repute to share with us their knowledge about a particular topic of interest. And throughout the year, we had 3 international webinars. And then annually, we have annual seminar where we use our anniversary celebration to organize a webinar where we invite some international experts like what we are witnessing today. So this, the method is just like a plant. You plant a seed, then you continue putting water and other things, and with expectation like one time it will grow and have some benefit to other people. So just like what we have in PSI, in December 2017, that's when we planted the seeds. And now throughout these 5 years, this is what we are witnessing. That's the impact. That's what we can see or what has been recorded. Other ones, there are so many that we are unable to record. So many PSI members have become certified clinical researchers. And this is very important for someone who is doing research in clinical areas. Like I know in so many universities, you cannot perform any research without this certification. I could remember while I was doing my master's in University of Science Malaysia Teaching Hospital, I was asked to present this certificate while I was processing my ethics approval. So it's very good, and most of our members have done the courses and they are now certified researchers. Again, many of our members joined the famous Global Burden of Disease Collaborator Network. This is like one of the top evidence that they provide evidence regarding to my disease morbidity, especially for long-term illness. So most of our members have joined, are now full members of the Global Burden of Disease and Collaborator Network. And also from inception to date, we are able to conceive, conducted and published 13 research. And all these papers have been published in high impact journals and currently making impact in scientific community. And through our activities, some members were inspired to conduct some studies. So like I said, the all major of mentoring is to have a positive impact of other people. And this is what we witness in PSI. So through this PSI inspired research, and this is as defined by one of our key member, Dr. Basira Kankia, she came up with this definition. So PSI inspired research is a study that was inspired by discussions, knowledge sharing, or motivation by other PSI members, which resulted in the research being conducted. And she made this definition in 2021. So through this inspiration, 23 papers or research has been published through PSI inspired research. And one of the most cited paper among these is this assessment of COVID information overload among the general public, which was led by Mustafa Mohammed, and we have some collaboration from the US and Malaysia and Australia as well. And then another scientific impact of our research is total. That's the PSI research and those that have been inspired by PSI's mentoring activities. They received 148 citations across the world. That means different people, scientists across the world, 148 cited our research just to make the evidence stronger or to demonstrate more evidence using our findings. And one of our papers, that is the COVID information overload, is the most cited paper in COVID information, COVID-19 information overload literature in the world. You can search it in Google Scholar if you want, or you can contact me for more details. And all this, our research has been hosted by 20 international repositories. This includes the National Library of Medicine, US, and also WHO and so many repositories, some in Portugal, some in North America, some in Europe, and so many other countries. And also it will be interesting to know that 4 of our papers have been used or have been posted or have been hosted by WHO to illustrate evidence about COVID-19. It is very, very happy. I mean, I don't even know how to describe it, to see your work that you did through mentoring and a body like WHO hosting your research on its web page to tell the world about information about or to strengthen evidence about COVID-19. I think this is one of the hallmark of being a mentor. I mean, of happiness of being a mentor. So in addition, through our international webinar that we conducted in the past, the first quarter we did was where we invited Dr. Nasruddin Al-Awwal, who is from the US. He gave a webinar about detection of viable E. coli using nanoparticle immunofluorescent probes. It was very, very interesting webinar, and it's attended by so many people. And then we also had another one from an international expert from the UNICEF headquarters, that is Ibrahim Dardari, where he presented a very, very awesome lecture. And just lastly, we have another one, more of a hands-on training provided by Dr. Hamid Musbao from Australia, where he did a hands-on training on startup. And today we are witnessing another milestone, that is another annual webinar where we invited 2 international research experts of repute. And I'm happy, and the webinar is going to be chaired by our daddy, Professor Ahmed Timora. And I would like to thank Professor Mora for being with us. He has been supporting us from day one. From the first day we established this movement, we consulted him and he gave us his full support. Our first webinar in collaboration with the BUK, he was there in person at BUK. And the second one in 2019, he was also there in person. In fact, he was even there 1 hour or 2 hours earlier than the time. And during in 2020, he was there as well during the virtual webinar. And today he's here with us. He is right now in the office at PCN. Thank you so much, sir, for all the support. And I would like to use this opportunity to welcome everyone to this webinar. And I hope we all learn from our 2 guest speakers. Thank you so much, and God bless.
Thank you so much, Dr. Ibrahim Jatto, the President, PSI. Thank you so much. And without much ado, I would like to invite the chairman of the occasion, our father, our mentor, Professor Ahmed Timora, to give his own remarks. You're welcome, sir. Over to you, sir.
No, that is Hadiza who will read his citation.
Okay, that's citation. Okay,
Dr. Hadiza, are you there?
Yes, I'm here. Thank you very much, Dr. Ibrahim Jatto. Let me share my slide.
Are you there? Dr. Hadiza?
Okay.
Yeah,
Can I share for you?
Yeah, I think that would be great.
Can I share for you, then you can read it?
Yeah, you can share the slides while she read it, maybe.
Okay.
If she has technical challenges.
All right. Okay. Oh, I can read. Maybe she can read for others.
Yes, because we cannot.
Yes, we can't wait.
Yeah, I think.
I can read it for her.
Okay, you can go on, sir.
All right, so I'm coming. Let me check it. All right.
Sorry for that.
Are you there? I should go ahead.
Hello.
Hello?
Okay. Okay.
Yeah, you can read from my slides, then I can roll it for you.
Okay, it's okay. Good day, everyone. I'm Adiza Yusuf. I'm going to read the citation of Professor Ahmed Tijani Mora, BSc, MBA, FPC Pharm, PhD, FPSN, FICEN, FIH, MN, FNIM, MNI, Kayayan Sarkin Musulmi, and Wakil Maganin Zauzau. and also the chairman, governing council of the Pharmacy Council of Nigeria. Professor Ahmed Tijani Mora was born on 13th May 1956, and he is from Zaria in Kaduna State. He attended, amongst others, in Nigeria, the prestigious Barewa College and Ahmadu Bello University, Zaria. It is no surprise why the name Professor Ahmed Tijani Mora is a phenomenal success. The Kayayan Sarkin Muslimi has rendered over 3 decades of meritorious and impeccable service to the pharmacy profession, which cannot be overemphasized, some of which are: it was the prime mover behind Zarin Jet disposable syringes and needles, the largest disposable syringe manufacturing company in West Africa. He proposed and saw to fruition and publication of 4-part compendium of minimum standard of practice for the assurance of pharmaceutical care in Nigeria. The compendium was the first of its kind, which serves as a benchmark of quality and excellence in pharmacy education in Nigeria. The 4-part compendium is also the first published book of its kind by any of the 8 regulatory agencies in the history of healthcare regulation in Nigeria. He significantly broadened the scope of the pharmacy profession under the aegis of the Pharmacy Council of Nigeria as the then registrar of the council. While he was the registrar, he championed the successful transformation of the Pharmacists Council of Nigeria through his dedication, effective foresight, and measurable results, which knew no bounds. His appointment to run for a higher position was therefore foreseeable. The Kayayan Sarkin Muslimi is a receiver of numerous awards and fellowship to fit his charismatic personality. He received an Eminent Person Award of the Nigerian Association of Industrial Pharmacists in 1998, award as a benefactor of the Faculty of Pharmaceutical Sciences, ABU Zaria in 2004, Pharmaceutical Leadership Award as African Executive of the Year 2009 by African Leadership Magazine in 2010, Golden Leadership Icon Award by Presidential Dairy Magazine in 2021. It was also nominated as the most distinguished alumnus in the history of the Faculty of Pharmaceutical Sciences, ABU Zaria, at the 50th anniversary celebration. He is a fellow, Pharmaceutical Society of Nigeria in 1997, fellow West African Postgraduate College of Pharmacists in 2002, fellow Institute of Health Management in Nigeria in 2012. He has attended more than 270 conferences, workshops, seminars, and symposiums from 1988 to date. That's 30 years in Nigeria and abroad. He has authored and co-authored 9 books that have been published with ISBN. He also edited more than 22 books, most of which are geared towards the advancement of the pharmacy profession. A million words will not suffice to describe the immense support Sarkin Muslimi rendered to the Pharmacy Scholars Initiative for 4 years till now. We are thankful and appreciative to all his efforts. To us at Pharmacy Scholars Initiative, it will remain an embodiment, kindness, and perfection. Permit me to welcome our father, the father of the day, Professor A.T. Mora, B.Pharm, MBA, PhD, MNI, FWAPC Pharm, ASCON. You're welcome, sir.
Hello, sir. You need to unmute. You need to unmute your, yes, sir.
Yes, the mic.
Can you hear me now?
Yes, sir.
Okay.
Loud
I
and
said
clear.
while Hadiza was reading the citation, I was thought it was somebody else, not me. You know? Thank you very much for that. Honestly speaking, let me begin by congratulating the members of the Pharmacy Scholars Initiative on this day. This has been a routine of a sort. I remember exactly on the 3rd of December last year, actually I was in Oka, Anambra State, during the delegates conference of the Nigerian Association of Pharmacists and Pharmaceutical Scientists in the Americas. Sorry, please, sorry, the association of the conference of the Alumni Association of the Nigerian Universities, Kano. I was the national chairman then, and I took time off, if you recall, during the in-between the delegates conference to speak to this gathering. And as fate will have it, it was in Bayero University on exactly the 3rd of December, again, this year, when we had the delegates conference and handed over after 6 years of service as a national chairman of the Conference of Alumni Association of Nigerian Universities. Bring in Bayero University because that's why it all started. And I want to thank Dr. Ibrahim Jato Abubakar, and I want to thank Dr. Abubakar Isa. I want to thank other promoters of the then Young Pharmacist Scholars, which is now Pharmacy Scholars Initiative, because I asked them the question, will you continue to be young? You'll have to be like us, you know? So if you say young is relative, then I told them that time that I also qualified. I was young that time. I said to myself, I'm happy that the name has been changed to PSI, which is quite appropriate. I really want to celebrate with you on this day, on the 5th anniversary, because I was there in Bayero University twice, face-to-face, and I was there twice, virtual. This is I mentioned the last one in Oka, Anambra State, that was 2021, 2020, I think I did it in my house in Kaduna, and this is the 5th one. I really have to encourage you continually, because to put in people together like this is not easy. And especially Dr. Ibrahim Jato Abubakar, you have done very well, and hardly a week will pass without my contacting Dr. Ibrahim Abubakar for one thing or the other, either by text or by email. I think he has given the initiative a very good direction, and please keep it up.
Thank you, sir.
So having said that, I'm happy that today you have 2 speakers that I'm very familiar with. Dr. Danraka, who was in AB with us, and he's here behind us in NIPRIT, National Institute for Pharmaceutical Research and Development. And I think Dr. Kujiyat, he said he was a classmate.
Yes, sir.
ABU, right?
Yes, sir.
Yes, so we my student too. And that name rings a bell, because I think he's related to, or maybe the son of Dr. Sam Kujiyat, who is a veterinary doctor. I don't know if I'm wrong, because Dr. Kujiyat is from Kaduna State, of course, from the name. He was my teacher in mathematics in Bariau College when we were in Form 2. And I think Dr. Ibrahim Jato Abubakar, you are not born that time.
Yes,
Neither
sir. All of us.
Neither was anybody born that time, because I was in Bariau College. He was our teacher that time. I'm sure he must be his son.
Yeah, he is.
Dr. Kujiyat read veterinary medicine. It was an inspiration to us in my class in teaching mathematics. And I think he's a clergyman now with a position in the Vatican in the Rome. I don't know, maybe, possibly, yes. At any rate, I'm happy to observe that these 2 scholars will be making a presentation. That's how it should be. Now, I'm delighted to chair the session and also to welcome you all to this 5th anniversary webinar 2022 of the Pharmacy Scholars Initiative on the theme, and I quote, bridging pharmaceutical research outcomes to impactful government policies in low and medium income countries, LMICs, holding on this day, the Sunday, the 18th of December, 2022. First and foremost, I want to congratulate the organizers and conveners of this webinar for the choice of the theme that is apt, considering the constituency that is pharmacy, that majority, if not all, of the participants at this program belongs, and also because of its relevance to our dear country, Nigeria, which of course makes the list of the LMICs. According to the World Bank benchmarking, the LMICs are those countries with a gross national income, GNI, per capita between $1,036 and $12,535. That's according to World Bank ranking in 2021. And such countries are home to 75% of the world's population, and unfortunately, 62% of the world's poor. Also, such countries are facing social, economic, environmental, human capital, political, and infrastructure issues that are directly or indirectly affecting the healthcare sector and pharmaceutical service delivery. When it comes to the subject of impactful government policies, I believe Nigeria cannot be found wanting, except for committed implementation of same. And I can say that boldly, having been a participant at the National Institute for Policy and Strategic Studies in Kuru. And I know that we have them, the policies that are there just waiting to be implemented over time. I want to also state that many LMICs have appreciable number of impactful policies, but they suffer similar malady of poor implementation. Therefore, one of the solutions to addressing the theme of today's webinar is handy, that is, existence of impactful government policies. To the curious mind at this session, permit me to state that impactful government policies are those that address, stimulation of inclusive economic growth, economic and institutional reforms, establishment and promotion of microfinance institutions and programs, improvement of the marketing system, cash and income transfer programs, establishment of societal security system and other safety nets, and protection of the poor, the disabled, the elderly, and other vulnerable groups, among others. Please quote me rightly as I lay emphasis on existence of plethora of impactful policies as against actual and faithful implementation of same. In any event, that any LMIC is incapacitated to formulate impactful government policies, the United Nations has recently adopted a global approach to stimulate policies, to stimulate and catalyze development among the developing and underdeveloped countries through the Millennium Development Goals, MDGs, between 2000 and 2015. We remember our sister, Dr. Amina Mohammed, the Deputy Secretary General of the United Nations, has done a fantastic job in the aspect of Millennium Development Goals in Nigeria, which is later now known as Sustainable Development Goals, which is currently being implemented with its commencement in 2015 through 2030. The goals and targets set for both the MDGs and SDGs address the above-mentioned issues and menace that characterize the LMICs. To my mind, the assignment left for us within the pharmaceutical landscape is to ensure that our pharmaceutical research outcomes, as mentioned by Dr. Ibrahim Jato, are aligned with the course of principle of action and the statement of intent of the respective countries' plans in an implementable manner. Furthermore, the extent or degree to which the foregoing can be accomplished is a function of the type of pharmaceutical researches we undertake. In this regard, we need to conduct a blend of basic and applied researches with more emphasis on applied researches. In the same vein, a mix of qualitative and quantitative research methods should be adopted to capitalize on the strength of both methods of our own advantage. You may wish to recall that last year, actually on the 3rd of December, significantly, I talked about quantitative and qualitative research. In addition, there is a need to pay particular attention to translational researches with multidisciplinary approach that harnesses the area of core competence of various investigators and researchers with a view to solving our nagging problems. Distinguished ladies and gentlemen, the President of PSI, the Secretary, members of ESCO, I hope that a careful consideration of this preamble of mine will only serve a purpose of sensitizing participants to listen attentively to the guest speakers, whom I have no doubt my mind will deliver is appropriate. And I'm sure they will do justice to the topic. Once again, I welcome you to the webinar and enjoin you to have participatory, fruitful, and rewarding sessions. Thank you for listening and for your attention. Thank you and God bless. Thank you.
Thank you. Thank you so much, sir, for the wonderful opening remarks. So, without much waste of time, as we've actually highlighted earlier, we will go into the event proper. Thank you so much once again, sir.
Thank you very much.
Thank you. Our first speaker is going to be Dr. Danraka. And before then, I would like to still invite Dr. Hadiza Yusuf to give us a citation on Dr. Danraka. Thank you so much, Dr. Adiza. Please, the floor is yours.
Adiza,
Thank you so much. Okay.
Let me share the slide for you. To make
All
it
right,
easy.
all right, all right.
Is it there?
Okay, thank you very much, Dr. Abubakar Jato.
And come here, let me.
Good afternoon once again, everyone. I'm going to read the citation of our distinguished speaker, Dr. Abubakar Danraka. Dr. Abubakar Danraka. Sorry, I need to make some adjustment on this.
Are you ready?
Okay, all right. Dr. Abubakar Danraka, FPC Pharm, PhD, MIPAN, is the Zonal Coordinator, West African Postgraduate College of Pharmacists in Nigeria, Abuja Zone. Dr. Danraka is a Nigerian pharmacist consultant with specialization in drug production and pharmaceutical quality system. He has over 15 years of experience in hospital and administrative pharmacy practice with over 40 publications and scientific presentations as contribution to knowledge and practice to his credit. He is a health sociologist with an interest in public health and social pharmacy research. He is also a certified public analyst with a major in drugs, cosmetic, and medical devices. For his educational qualification, Dr. Abubakar Danraka attended King's College, Lagos, at Ahmadu Bello University, Zaria, for his bachelor degree in pharmacy, and also University of Abuja, Nigeria, for his Master of Science and a degree of Doctor of Philosophy. Dr. Abubakar Danraka has attended several training, among which are West African Postgraduate College of Pharmacists, Nigeria Institute of Management, Institute of Public Analysts of Nigeria, the University of Washington, USA. He has participated as delegate of Nigeria in many multinational and bilateral engagements on health and well-being within Africa and global context. Dr. Abubakar Danraka is a visionary leader and passionate advocate of common humanity for the advancement of equal opportunity in development, particularly access to health and education. He is happily married and blessed and with a blessed family. In today's webinar, Dr. Abubakar Danraka will be presenting on the topic, promoting impactful pharmaceutical research for national development. So ladies and gentlemen, join me to welcome our distinguished speaker, Dr. Abubakar Danraka.
Thank you very much. The chairman of the webinar, our own father, has rightly introduced our mentor and our professional guide, Professor Ahmed Tijani Mora. I dug my heart to you, sir.
You're not wearing one.
Want to. Thank you. It's imaginary, sir.
Go ahead, Abubakar.
President of the PSI ESCO, I want to profoundly express my appreciation and the gesture of inviting me to this important webinar and discourse. I'm grateful for this opportunity and I don't take this for granted. Without wasting much time, as was rightly said, today is a World Cup day, finals day. So let's just go straight into my presentation. It's actually a short presentation, but I tried to highlight all the areas necessary to align with the team, and the chairman of the occasion has done justice to give us a good background on the team. Please kindly share the presentation from your side, Dr. Ibrahim Jato.
Okay, sir.
The topic of my presentation is, as advertised, is promoting impactful pharmaceutical research for national development. And I decided to put in some few thoughts that are on the conversation. It is important to state that you cannot talk about pharmaceutical research and national development without giving the context of the discussion. Next slide. So essentially, the thematic areas of my presentation are pharmaceutical research, national development, translational research, and I think it is important for the purpose of this presentation to also talk about researchers' reorientation, because that is what will bring about the solving the gap and in ensuring proper implementation of policies developed and research out findings. Next slide. It is important to a little tinkle with our mindset, because I have had a lot of conversations with many academics, researchers in pharmacy, and what I discovered from anecdotal assessment is pharmaceutical researches are limited to just an aspect or scope of pharma research. On this slide, I try to share to us that when you are going to do justice to pharmaceutical research, you must take it the whole hog in the entire 3 scopes of pharma research. And these are the 3 areas I highlighted: drug discovery and development, drug utilization and handling, and as much as possible, drug waste management and recycling. Under drug discovery and development, we are all familiar with our basic areas of research, from pharmaceutics to pharmaceutical chemistry, medicinal chemistry, pharmacognosy, pharmacology, and all that you have in pharmacognosy. So this area focuses on production, design, characterization, standardization, quality analysis, formulation, the whole gamut of preclinical and clinical trials, the ethical evaluation and regulatory affairs concerns in terms of approving, as my professor will say, I'm our mentor daddy for today, the 3-dimensional product needs to be regulated, because it's not aligned, it's not similar to other commodities. This is a specialized commodity. And within the same scope of drug discovery researches, you also have pharmaceutical engineering and fabrication. The second domain of pharmaceutical research, which is not very well pronounced amongst pharmacists in academia, is the drug utilization and handling. Because after all the concepts or the activities of drug discovery and development, the drug is being approved and validated for use in the population. So what happens to the product in the population amongst the citizens and the entire global pharmaceutical market is what the drug utilization and handling tries to focus on. And that is the rational drug use, dispensing, pharmacovigilance, logistics and supply chain management, the pharmacoepidemiology, pharmacoeconomics, pharmaceutical and drug-related policy development, pharmaceutical sociology, of how this 3-dimensional product is utilized and accepted. Because at this stage, it is important to also relate that we shouldn't be clouded with seeing drugs as just as we think they are. What the people perceive drugs to be is key, because that's where the pharmaceutical sociology, which is a subsect of health sociology, tries to focus on as much as possible. We are aware of the WHO presentation and find report that more than 80% of our population in sub-Saharan Africa actually access their healthcare needs through the traditional and complementary medicines. So what medicines are to people is a concern to pharmacists, and we need to research into them. Then the last but not the least is the drug waste management and recycling. So after the drug has been released to the people, to the population, what happens to it when it's expired? There are a lot of researches that are done on extension of shelf life for expired drugs, and possibility of using, and also drug repurposing. Some medications that have been off use are now coming back because of continuous diseases and infections that are bedeviling the world. Then the green disposal of expired drugs. Next slide, please. The next slide tries to highlight what national development is all about. I'm glad for the team that was well elucidated by our chairman of the day. You can't talk about national development without referring to sustainable development goals and what the status of human development is. Human Development Index actually is that composite repository of assessing the level of, as Professor Etimora rightly said and quoted, it tries to show the ranking of countries of the world according to this index, which focuses on life expectancy, education, and per capita income, which are markers to human development. And as much as possible, that Human Development Index is categorized into 4 tiers. You have the very high category, then the high category, medium, and also the low category. Unfortunately, the 2022 report was released, that is on 8th of September, out of 66 countries that made the very high category. I report to this gathering that none of the African countries met that category of the very high. So we, Nigeria, and a lot of sub-Saharan African countries are within the low and medium income countries. And it is important to report that research is vital for economic development. Our researchers, young researchers will have that at the back of your mind. And it is very vital to the realities in the low and middle income countries. Next slide, please. The other thematic area of interest, next slide, is our translational research. Translational research, please. Translational research is important to state here that you cannot have impactful researches without translational research. Translational research is an important aspect in biomedical research, where you have the bench to bedside and also operational researches, because these two are important. Many a times researchers focus on bench to bedside as the only translational research, but indeed, operational researches are also key because they are the researches that go into the field and the outcomes impact on policy and practice of professionals. And the goal of operational researches is actually to increase the efficiency, effectiveness, and quality of services delivered by providers, and the availability, accessibility, and acceptability of such services as desired by users. So next slide. The last thematic area is we can't talk about ourselves in this gathering, even though I know that there are other participants that are not pharmacists, but essentially being a pharmacy scholars initiative, our role as pharmacists is well defined by the Federation of International Pharmacists as a 9-star pharmacist concept. One of that star is being a researcher. So as a pharmacist researcher, it is good to focus on those areas of research that are not only limited to drug discovery. We should go ahead and venture into drug utilization and handling, as well as drug waste management and recycling. And these areas are very numerous. They are in the phytomedicine and herbal medicine standardization. This is an area of strength for us in the low and middle income countries, because the Western world actually look up to us on this aspect. So orthodox medicine has its own limitation, but phytomedicine and herbal medicine is indigenous to us, passed on by our forebears. So we need to research into this and standardize them. Then self-care and self-treatment, clinical pharmacy, pharmaceutical care service delivery, drug therapy problems identification and resolutions, supply chain and logistics management, public health, health-seeking behavior and patterns, pharmaceutical quality systems, drug development and drug production management. These are all areas that are key for us to take our attention to. Drug utilization, drug misuse and abuse rehabilitation programs. What is happening? The drug that is supposed to be a savior, that is supposed to be impacting health, is causing a lot of havoc. And the falsification industry, that's drug substandard industry, is a huge global revenue earner to the cabals, that the barons that undertake it, tobacco and alcohol cessation programs, the drug waste management. What happens to our expired drugs? How are they taken out of the population? These are areas of interest that it's pharmacists that are supposed to lead in these areas. Next slide, please. Here, it is important to talk about researchers' reorientation because unfortunately, our academics in pharmaceutical research are, I don't know where we got it wrong. The research, that is the publish or perish syndrome, has bedeviled our ivory towers into areas where researches are essentially theoretical projects. That is, they are just things in the realm of ideas and concepts. I think there is that urgent call that our researches should be demand-driven for solution provision. As much as possible, young researchers need to unlearn and relearn to adapt to entrepreneurial orientation in all aspects of research. We need to deliberately focus our engagement and activities to become entrepreneurs. Nigeria and the entire low and middle income countries are endowed, in quotes, with problems. And a lot of scientists have said problems are indeed the raw materials for creativity and innovation. So you can say the low and middle income countries are landmines for researches because there are numerous problems anywhere you turn, from your environment to hygiene to environmental sanitation to name it. Even system failures, even the holds up you see and the traffic jam you see on our roads, our lack of pay, these are all areas of researches that we need to find evidential, empirical out of processes at all levels from undergraduate postgraduate. So this research endeavors to be guided by solving problems in our community and in our society, health problems, economic, and all multifaceted problems. Next slide, please. Here, what I try to focus on this slide, next slide, please, is the linkage, that is the nexus of how to promote the impactful pharmaceutical research for national development. I will say this is the key slide for the presentation, because the only way you can promote pharmaceutical research is to be impactful towards national development is if at the onset, our conceptualization of researches are aligned with research goals, are actually focused on SDGs, extant national policies such as the National Health Policy, the National Strategic Health Development Plan 2, and the National Drug Policy, etc. What I'm trying to say here is that you can already, the policies are already there and they are not implemented. So one of the easiest way to promote impactful pharmaceutical research is pick any national policy you can get at your disposal. Go through it and see where are we lagging, what is causing the non-implementation. Design your researches to focus on why are we not having such implementation. A case in reference is actually the National Drug Policy 2021 edition, where it is glaringly stated that it is expected that local pharmaceutical production will be attained up to 70% in the next 5 years. So what is happening? While we know over 80% of our drugs are imported finished products, and our APIs are 100% imported, our pharmaceutical excipients are over 90% imported. What is happening? What is the problem? I think these are areas of research. Then another area of promoting impactful research is when we adopt evidence-based policy development by the MDAs. Here I mean the ministries, departments, programs and projects and agencies of government should be backed by empirical findings from surveys and research. Ab initio, some of those policies, it's good to state that they were just policies that were sat down and developed. What were the needs assessment? What were the things that were done to show feasibility of implementation? So it's always good to start the policy development with the end at the beginning. What is the need assessment? What is the picture on ground? What are the strategic plans to implement them so that they are realistic, not just ambitious? And the last item on this slide is focusing on what I said earlier, that right at the inception of ideas, the development of study design or research endeavors from tertiary institutions, and not only tertiary institutions, including think tanks and other research institutions, should be tailored towards solving societal problems across all sectors. Next slide. The challenges, we can't end this conversation. I think this is a thought to the last slide on my presentation. We can't end this conversation without highlighting what actually the challenges are in conducting impactful pharmaceutical researches. And as I said, along the context of this presentation, pharmaceutical researches are within the 3 scopes I highlighted: drug discovery and development, as well as drug utilization and handling. Then last but not the least is the drug waste management and recycling. One key important challenge that a lot of young researchers face is actually in determining and framing the right questions at the bench level that have clinical relevance. And it is a huge concern. You will see a disconnect between academics at the bench and the clinical relevance of their work in the clinics and in the hospital settings. Another key one that is known to all is inadequate funding. There is hardly any endeavor you want to undertake that if you outline the budget, you will be wondering where the funding will come. I think it is good to state, maybe when I come to the way forward, funding is readily available from grants, and the TET fund is doing a lot in Nigeria towards that end, once the concept development is robust and all-encompassing. Then another important salient challenge, which I observed from an anecdotal assessment, is the non-due recognition of innovative concepts in product development and solving societal or industry problems. A lot of the assessments that are done for promotion of our academics do not give due recognition to innovative concepts. Somebody might have the large number of publication in high impact journals, but I can assure you that another person that might have developed a solution in the lab or solution or a product might not have similar credits that will earn him due promotion above his peers. And another key challenge is territorialism of researchers. It is known that a lot of scientists and researchers, especially in our climate, are operating in silos. You will see that there is a lot of duplication of effort and there is no synergy, and that is affecting impactful pharmaceutical researches, because the limited resources you have to conduct research, you are duplicating your efforts instead of synergizing to address issues collectively. The last but not the least, these challenges are actually not exhaustive, but at least these are the key I decided to highlight. The low morale to good attitude to work. There is a significant low morale to good attitude to work by a lot of researchers in Nigeria and within the low and middle income countries in sub-Saharan Africa. And this is largely alluded to multifaceted factors, such as inadequate remunerations. You hear of ASU strike and a lot of industrial disharmony and so on. Then there are issues of inadequate training and capacity development for researchers. Next slide. We cannot conclude this presentation without making suggestions to way forward. And I decided to highlight some of the way forward in this, our presentation. This one too is non-exhaustive. Many way forward are there, but among them is young researchers need to adopt entrepreneurial concept in research as an enterprise. When we start seeing research endeavors as revenue earners that will earn us patent and intellectual property, where we will be earning royalties. Once you patent your innovation and development of products, you will commercialize it, and there are a lot of commercial entities that are ready to pick up, and you will be getting your alerts on a regular basis while you continue your research endeavor. So most importantly, we must have that self-reorientation that we should see our research endeavor as an enterprise. We should have the entrepreneurial philosophy behind it. Then we need to adapt to project-based learning and scholarship as much as possible. Even though we need as much as possible to be very clear in our concept and ideas, but as we should relate to how those theoretical concepts lead to impactful projects that solve the problem of community. Then product and services development to be duly recognized above just theoretical publications. So as much as possible, this is a clarion call to our assessors that whoever is able to develop impactful product and services that is solving the needs of the society should have high points. It shouldn't be just mere 2.1 point. It should have the highest allotted point in that category of assessment, so that there is incentive for researchers to actually take their activity, research endeavors to solving society's problem. Academics should create platforms in universities for periodic engagement with practitioners, policymakers, and industry through sectoral advisory boards for sustained collaboration and networking between researchers and other stakeholders. I think this is important. I am one of the members of a sectoral advisory board at the Nile University. I know that what that sectoral advisory board is doing at the Department of Biochemistry is not small, because academics are exposed to real life policy critical areas, and the relationship is actually mutually beneficial. The academics benefit from the industry people, and as well as the industry people benefit from the academia. Young researchers should seek for mentorship through networking with researchers that are involved in real translational research projects. The platform of the PSI is key. From the presentation of the president, it is clear that when researchers see that what they do is impacting policy at the highest level of health, that is the World Health Assembly, World Health Organization, they are incentivized to know that the little they do is actually impacting on policy. The next important way forward is we need to dismantle silos and establish synergy, as I said, so that there could be cross-fertilization of ideas between academics and also policy and industry workers. This brings me to the concept of quadruple helix model. Essentially, it started as a triple helix model, where it is the marriage between universities, academics, industry, and government. But the model is further enriched to become a quadruple helix model, where the citizens need to be carried along. As much as possible, if citizens are left alone, you will have a myriad of problems when you come to clinical researches, that is the clinical trial and buy-in of the citizens. So in needs assessment concepts, we need to engage the citizens, which is the community. I know the challenges we are facing at my institute based on the clinical trial we are doing in SafeCovan, that's the safety and immunogenicity of fractional doses of COVID-19 vaccines. The buy-in of the community is key in the success of that clinical trial, and that's why the quadruple helix model is the key thing. Last but not the least is the introduction of the federal government incentive scheme. This is a clarion call to the government of the day that translational researches and development for pharma sector and intellectual property should be incentivized with a clear scheme that if you are able to solve a problem that government implements, you have royalty and you have something to be happy with. This will change, it will be a game changer in the issue of impactful pharmaceutical researches. Last slide, please. My last slide is just the conclusion. where for pharmacists to remain the backbone in pharmaceutical sciences as well as pharmaceutical service delivery, we should improve our competencies and capacity in line with global best practices in all the 3 relevant scopes of pharmaceutical research, development, and innovation for enhanced national development. Pharmaceutical outcomes research are important areas for sustainable translational research activity in the evolving healthcare ecosystem that will improve health and well-being of citizens and guarantee access to universal health coverage. Thank you for the attention, and God bless.
Thank you. Thank you so much, Dr. Danraka. I believe all of us can attest to the fact that justice has been served to this topic. And we once again thank you so much, sir, for taking the time to take us through this important topic. So we are going to use the next 10 minutes to freshen up and also ask questions, if any. And we would like to encourage people to ask questions in the chat box, or if you want to speak, you can do that by raising your hand. And I have an announcement. We actually welcome feedback, just like stated in the beginning. So I'm going to be sharing a feedback form for all participants to please fill. We are going to use that to get your email address to be able to send you certificates of participation. Thank you so much. So any questions before we head on to the next presentation? Okay, I can see David Kunshaw.
Okay, maybe I think we can. I think we can have the questions at the end of the presentation.
Yeah, I think so too.
Yeah.
It's all right.
Let's see the next presenter.
Yes.
Oh, okay. So let us go straight to the next presentation by pharmacist Kujiyat.
Timothy.
And Timothy Kujiyat. Before then, as usual, I will call on Dr. Hadiza to please read us the citation on pharmacist Timothy before he starts his presentation. Hadiza Yusuf, over to you. Dr. Hadiza, are you there? Maybe as usual.
Yes, I'll come. I'll prepare the slide for her. Then I think it's easier. Okay.
All right. Okay, David Funshaw, please will attend to questions at the end of the second lecture. And
that's very fine. Thank you.
All right, questions can start coming from the through the chat box as well. So we'll attend to them at the end of the second lecture. Thank you. So Dr. Hadiza, are you there?
Dr. Hadiza, are you there? Okay, that's just to save time. Let me just do it before she joins.
All right, you're welcome.
Good day, everyone. Please join me to introduce our special guest speaker, pharmacist Timothy Akau Kujiyat. Pharmacist Timothy is the lead clinical pharmacist at Primary Care Networks in the United Kingdom. And his early education, he did his B.Pharm degree at Ahmadu Bello University. As I said earlier, he's my classmate, and Abubakar Shaban and David Foley. And he has done his postgraduate studies at Robert Gordon University, Aberdeen, Scotland. Also, he also had another postgraduate degree from the Montfort University in England. Pharmacist Kujiyat Timothy has done postgraduate certificate diploma. Has done his postgraduate certificate in clinical pharmacy and another additional postgraduate certificate in independent prescribing. In terms of his professional career, Pharmacist Timothy was a medical rep at Oculus Pharm in Nigeria. That's where he started his professional career in Nigeria. Then when he moved to the United Kingdom, after his internship, he started as a relief pharmacist at Lloyd's Pharmacy, which grew to become a pharmacy manager position in charge of so many other pharmacy staff in the company. Pharmacy Timothy also worked at the general practice where he worked as an independent prescriber. You could recall he had his postgraduate certificate in independent prescriber. Also, he started as clinical pharmacist at primary care networks in the UK, which climbed the ladder to become the lead clinical pharmacist in the same network. Pharmacy Timothy, as I know him, even in the Ahmadi Bello time, he blends pharmacy with some politics. So in the UK, also outside pharmacy, Timothy is also a member of the Labour Party in the United Kingdom. And it may interest you to know that Pharm Timothy also contested. He contested an election on the same party, that's the Labour Party. And he's also so versatile, pharmacy, politics, and also in the community service. Pharm Timothy also holds position on the local government board of his school sons, where he served as the parent governor, where he stands as representing the interests of other parents. Pharmacy Timothy is happily married with 2 beautiful children. And in today's lecture, my colleague will be, and our special guest, will be presenting on the topic, managing long-term conditions as an independent prescriber in the UK. And you all recall, this is new to us back in Nigeria. And I think even in Australia, it's only some few states, I think Queensland, that are doing it. And it just, I think last few months that New South Wales and Sydney are trying to do, they are doing a pilot to see if pharmacy could be an independent prescriber. So it's good to learn more from our special guest speaker, Pharmacy Timothy Akau. Please, my colleague, join me in welcoming Pharmacy Timothy to the podium. Thank you, sir.
Hi. Hello, can you hear me?
You can hear you, Pharm.
Okay. Thank you.
Loud and clear.
Thank you very much. Thank you, Jato. First of all, I want to, it's no coincidence seeing Professor Moya here. It was a privilege for him to actually, I swear my oath as a pharmacist in front of my dad, and he actually called my dad out because my dad was like, I know him, and he came out and gave a talk even on that day. So you're perfectly right, sir. I'm Dr. Kujiyat's son, and I'm sure he'll be very, very pleased to hear. In fact, I'm going to call him after this to tell him that I shared this occasion with you. So it's good to see you, sir, and I'm very, very pleased and happy to be here. Also, thank you to my colleagues, Jato, Shaaban. They kind of roped me into this to share, and I was like, what am I going to share, but I decided to come. So thank you for the opportunity. And while listening to Dr. Danraka, I had to bring out my pen and book, and I've just been writing and been jotting down a lot of the things that he's been saying. It was quite, I don't even know how to follow up from that presentation. And it seems like a little bit different from what he's actually spoken about or what the theme of the webinar is all about. But I think it just gives us a sneak peek into pharmacy practice here in the UK. And hopefully we can get some ideas on how things can also be done in Nigeria. So it's quite eye-opening. I practiced just about 6 months before I left. So hearing what's going on is quite informative. So that's very good. Are you going to share my slide, or do you want me to?
If you can, that'll be fine.
Let's see.
Or if you think, are you?
Is it there?
Yeah,
Yes,
it's here.
it is.
Yes,
You can click, you can just click on the PowerPoint mode. So that, yeah.
Yeah.
Perfect.
Okay.
Perfect. Is
Perfect.
here.
So, perfect. Okay. So it might be. I'll try and be very, very quick. I know we've really gone beyond time. And I don't want us to lose focus with what Dr. Danraka presented, because I believe, and I think that's the core of why this webinar has been put together. And like I said, I have my paper here. I've written down quite a lot that he said. I'll probably ask Shaban and Jato to kind of go through with me later on. So I'll try and just be quick with this. It's kind of more of an insight on independent prescribing in the UK, the merits and demerits, and how it's been implemented. Like Jato has said, it's something that is coming to fore in few countries. Is not generally kind of well accepted, but the UK is kind of pushing hard in getting. In fact, from this year or from next year, all pharmacy students in the universities in the UK here would graduate as an independent prescriber by default. So they're going to add an extra year for them of study. So as they are graduating as pharmacists, automatically they're graduating as independent prescribers. So it's taking a big push here in the UK, and it's something that I've been involved in. I've been an independent prescriber since 2018. So it's just to give us, it's not going to be detailed. So I don't want us to lose focus about the research, because it doesn't really correlate much with the research theme of the webinar. So it's just to give us a sneak peek of how it's done and what happens in the UK. Okay. So like I said, a brief background. The primary care is the bedrock of healthcare system in the UK. So everybody has got a general practice, or we call it surgeries here, where you have general practice doctors, and you go in there for your minor ailment. So I have a headache, I have a leg pain, I have this. You go to see your GP, as it's called here. Also, the GPs or the primary care, they manage long-term conditions. So the doctors also do that. So you get a diagnosis from a specialist most times, and they put you on certain drugs, and then they hand you back to your general practitioner, who kind of manages you, does your reviews, see how you're getting on with your medications, see if you have any issues and things like that. And the general practitioners can refer you back to your specialist. So that's kind of the bedrock, is quite ingrained here in the UK. The primary care network is the bedrock of healthcare, because that's the first port of call for patients. And with that as well, there's focus on prevention rather than cure. So the GPs, the general practitioners as well, try and preach or share ways you can prevent. So instead of you having a heart attack, they'll try and prevent you from having a heart attack. So they do a lot of checks, check your cholesterol levels annually, do all those blood tests. And if you're having high cholesterol levels or high blood pressure, they'll place your medications. The aim is so you don't have a heart attack or a stroke down the line and then end up in secondary care. So there's a lot that the primary care networks do through their general practitioners. But the problem that the UK now is facing is there's a dwindling number of general practitioners. Doctors are leaving the UK, going to places like Australia, Canada, because of the demand that they face here. It's quite a full-on thing. So for better weather, for better pay, for less stress, well, a lot of general practitioners are going away from the UK. And what has that happened? What has that led to? The focus of care in the primary care networks has dwindled. So this has opened the door now for clinical pharmacists to step in. So instead of your general practitioner, your doctors, your GPs doing your long-term conditions checks, checking if your BP is well managed, changing your meds, increasing your dose, the clinical pharmacists we are now key to this. We now hold that role. We now assist in a way. So the GPs that are there can focus on proper medical stuff, things that we don't have expertise on. So, and to push that on, the UK has seen that training pharmacists as independent prescribers is key. And one of the reasons is, if as a clinical pharmacist in a GP practice, you come to me and in an annual high blood pressure check or hypertension check, your BP is raised, I want to increase your ramipril, for instance, from 2.5 to 5. And you in the past, I'll have to send you back to the GP or the doctor to prescribe or to issue you the script, you know. But because I'm now an independent prescriber, I can follow on that changes. I can actually make the changes and prescribe the medication to you and tell you to come and see me in 2 to 3 weeks. So that's what's opened the room for clinical pharmacists as independent prescribers to step in. So just a quick background. Long-term conditions are also called chronic diseases. They are conditions for which there's no cure, and they are managed with drugs and other treatments. So they tend to last a year or longer and have an impact on a person's life. So they include different facets. So it can be physical health conditions such as diabetes, hypertension, heart diseases, asthma, COPD. They can also include arthritis, so rheumatoid and osteoarthritis. They're all what we call long-term conditions. And then others are mental health problems such as anxiety or depression, which is a big thing here, or schizophrenia for the psychiatrists managed. They can also include chronic pain. So frailty. With new medications now, you have a lot of older people living longer with a lot of long-term conditions. And then we also talk about alcohol and substance misuse as long-term conditions as well. And also, when one person has one long-term condition, you just say, okay, you've got hypertension. But when you've got more than one long-term conditions at the same time, then it's what we call multiple morbidity. And majority, 60 to 70% of patients have got multimorbidity. So more than one long-term conditions all happening at the same time, but which one of them must be a physical health condition. So basically, there are two ways that these long-term conditions are managed in the UK. Like I said initially, the self-management. So this refers to tasks patients undertake to live with one or more chronic conditions. So they would include their own medical management. So the medications that are given to them, they have to manage themselves. They have to make sure they are taking them. They have to make sure they're reporting to us if they have side effects and issues with the meds. And then they also have we have the role management and the emotional management of their condition. So this is basically managed by the patients themselves. Now, the other one is the patient-centered care. And the core of this approach is medicines optimization. And I'll just link it to what Dr. Danraka was talking about when he was talking about the 3 scopes: drug discovery and development, drug utilization and handling, drug waste management, and recycling. So to me, I've written it down here. I didn't plan for this, but I feel where the medicines optimizations aligns with what he said is the drug utilization and handling. So those medications that we give patients to manage their long-term conditions, how are they utilized, how are they handled, you know, how do we deal with waste? That's another thing we look at with meds optimization. There's a lot of wastages that happen here. So how is that handled? So basically, as the clinical pharmacist, that is what we kind of look at. The patient-centered approach or the medicines optimization is the key area where we come in, and performing that role as an independent prescriber helps, because you can go into the prescribing, you can go into changing meds, you can go into stopping things, you know, depending on what you see. So in this approach is a lot of shared decision making and evidence-based practice. They're quite very essential. And the key thing that is involved in this patient-centered care is medicines reconciliation and medication reviews. So from that, where does the clinical pharmacist come into the picture? And like I said, the key thing is medicines optimization, safety of meds, and the patient care-centered approach. One is through medicines reconciliation. So when patients go to see their specialist in the clinic, they've got a diabetes specialist, and he goes through their meds and says, I want to change things. He writes a letter to the general practice, as to us, and says, okay, I'm changing this. It now comes to us, and then we do a reconciliation. We look at what they used to have previously before they had their review and what they are having now. And then we make sure that we change their patient record. We start the new medications, and we also do checks to make sure that if they have other long-term conditions, remember the endocrinologist who checks their diabetes doesn't know or doesn't really, his business is their diabetes. They might have rheumatoid arthritis that is managed by the rheumatologist. And they might not know that the rheumatologist, the patient is having methotrexate, for instance, for their rheumatoid arthritis. And he might place them on a medication that maybe interacts. So when it comes to us as clinical pharmacists, we have to do that reconciliation and see, okay, you've been given dapagliflozin, this medication for your diabetes is new. Does it go with your medications for your arthritis? So we play that key role. And if there's a problem, we write back to the specialist to say, you have asked to start this, but there's an interaction, or this combination cannot go. What do you want us to do? We can probably maybe suggest, sometimes we suggest, but because they are specialists, we just wait for them to kind of answer. So that's a key area. It's called medicine reconciliation. We do medication reviews, and it's usually done annually. Some people 6 monthly, but majorly is annually. And what we do, we just check their medications, their long-term conditions, make sure they are okay with the meds. There's no problems. We do their blood pressure checks. We do their blood monitorings as one of the points there. And if there's any changes, because we are in charge of managing those long-term conditions, we can actually make those changes. We can actually request that they do repeats a blood that is maybe abnormal, or a blood pressure is raised and we want to increase one of the medicines. So that's what we do during the medication review. And it's quite detailed. We also have a chance, because it's patient-centered, we allow the patients to kind of speak to us and tell us how you coping. Some of them have 15 medications, which is in line with polypharmacy down there, polypharmacy review. So we kind of ask, how do you cope? How do you cope with so many meds? So that's what a medication review is all about. I talked of dose optimization. For example, hypertension is a long-term condition. We check it annually. If they come to us during the clinic and their blood pressure is above the target, and then we follow the protocol. We either increase the dose or we add another agent, depending on what the protocol says, and we follow them up. Regular blood monitoring, that's something else. That's something we do. Those on what we call high-risk drugs, so those that have rheumatoid arthritis and they take medications that can affect their bloods, they have 3 monthly bloods, and it's our duty and our job to make sure that they have those bloods done and the bloods are within the parameters that are meant. So there's quite a lot. And we also check disease progression. We check for improvement checks. We do the polypharmacy review. In the UK here, anybody on 10 or more medication at the same time, so probably having 3 or 4 long-term conditions, is called polypharmacy, numerous meds. And we do those reviews. And the aim of the review is to see if we can, if they're getting on okay with the medications, or are there medications that they are on that they are not supposed to be on. And that's what the prescribing comes in. We can stop, especially with the elderly. We try and see medications that might cause them problems, maybe cause them to fall or cause confusions in the long run. And we kind of do the risk benefits versus risk to see if there's any need for them to be on those meds. And we also do frailty reviews as well as part of the medicine optimization process. So like I said, this is not really, there's no link to the theme of the day, which is research, but it just gives a sneak peek into what a clinical pharmacist, not all clinical pharmacists are independent prescribers. Some of them are on the way to are doing their courses. Some of us are, but generally this is what a clinical pharmacist does in a primary care network, which is the bedrock. So basically that's what it is. I'll just include this last point. So alongside the long-term management, clinical pharmacists, we're now being trained to see patients with minor illnesses. So which means when you're running your long-term condition clinics, maybe your hypertension clinic, and you're doing a review and the patient says, oh, Tim, while you're here, I have this rash on my leg. I've had it for 5 weeks. So we've been trained in those little areas where I can look at the rash and, I can prescribe a cream to say, let's try this. Or I can say, I've been going to the toilet quite frequently. We've been trained on just those minor illnesses, those minor things that they don't have to go ahead to say, doctor, we can deal with it there. So the bedrock and why the UK government is pushing this is because of the level of doctors that is kind of coming down. And it's not just pharmacists, even the nurses. We have nurse practitioners that are trained to run minor illness clinics. So pharmacists are playing a big role as well, and that's why that push is there. So that's it basically. That's generally what we do. And just to link it to what Dr. Danraka said, like I said, I've written quite a lot here. We need to, and I don't want us to lose focus on that, is we whether we're researchers or not, or clinical pharmacists or not, I saw he mentioned that in one of his slides. The key thing is the demand. We need to demand for researches that are driven for impact. So impactful pharmaceutical research, and it's something that we need to look at. Maybe areas, I don't know how the primary care networks work in Nigeria. I know I tried introducing a drug revolving fund when I served in Benue State, in the local government I served, but the politicians were not kind of buying into it. But maybe we need to look into researches. How do the primary care networks run in Nigeria? I know there are a lot of private clinics, but how can we link patients that are having long-term conditions with being managed regularly by the pharmacists, and improving that as a whole? So probably we need to do research in that area as well. See what's working and what's not working now, and see how we can develop that. So like I said, it seems to be not related to the theme of the day, but I believe I've been able to just give a sneak peek into how clinical pharmacy works in the UK, and how we, as an independent prescriber, we contribute a lot as well. So thank you very much.
Thank you so much, Timothy, for sharing with us how pharmacists in the UK actually participating in primary care, improving patient well-being. Thank you so much for the insights and the presentation. I know a lot of questions will come, especially from our clinical pharmacists in Nigeria, and I believe such questions will be attended to easily. So before we move on, I would like to recognize the presence of Professor Abdullahi Abba, who joined us while the presentation was ongoing. He's the current provost of College of Medicine, Kaduna State University. He's a professor of pulmonary medicine. Thank you for joining us, sir. You're welcome.
He said he needs a printer.
So we have two questions already for Dr. Danraka. Okay, Dr. Danraka, sir, are you there? We have two questions here that I'm going to read out for you.
Yes, I am here.
All right, sir. So one is from Kamilu, who said, how far about APIs local manufacturing in Nigeria? And is there any local manufacturing company that is currently producing APIs? That's the first question. Maybe you answer that, then we'll go to the next one.
Okay, that's fine, if that's the model. Thank you very much, Kamilu, for this question. How far with APIs manufactured in Nigeria? I think I mentioned it in one of my slides. Unfortunately, Nigeria is 100% importer of APIs. There is no single pharmaceutical company that produces APIs in Nigeria. Currently, efforts are on ground between EMZO Pharmaceutical and also our own agency, NIPRID, that we are pursuing to see how we can demonstrate and do pilot production of APIs in Nigeria. That is the unfortunate reality. We are 100% API importer in Nigeria. Thank you.
All right, thank you so much. The second question came from Samira, who said, in the community pharmacy practice, we generate a lot of expired medicines and we carry all to NAFDAC for destruction, which we feel as a waste of funds. If the community pharmacists want to get involved in research in expired medicines, recycling, and waste management, where can we get legal waiver to conduct such investigation? From pharmacist Samira Abubakar.
Thank you very much, Samira. I read your question on the chat box. I think this is a conversation that can commence with relevant technical groups. PSI, even interested, can lead it. Once we develop a concept, I said the most important thing is concept. A concept is developed to show the enormous waste that is there. We can actually design how we can undertake researches and apply to relevant bodies, especially PCN and NAV, to give us some kind of waivers, even at a pilot state, to undertake a research to see which are those expired drugs that can be suitable for extension of shelf life. Because essentially you cannot do extension of shelf life for expired drugs if the conditions of storage are not ascertained. So if community pharmacists under their groups or wherever can come together and reach out to PSI, the West African Postgraduate College of Pharmacists, or any of the groups, we can develop a joint proposal as a pilot, and I'm sure the relevant bodies, NAFDAC and PCN, can actually evaluate and review to see where needs for waivers can be done to demonstrate what we are trying to say. Thank you.
Sorry, can I come in?
Thank you. Yeah, I think I can see the presentation.
Yes, so thank you so much for asking this question, and Dr. Araka for this prompt response. So at PSI, this is one of the very idea that came up long ago to see how this could be tackled in Nigeria. So we now say, okay, it's good to identify the gaps. Then it is easier to provide an intervention if you know the evidence from the research. So we now conceptualize a research idea. It's an interventional study. So the first phase of the study is to identify the gaps. Then we are now having the stage 2 where we will design an intervention to address these gaps. So this was the study that was led by Dr. Salim Ilyasu from BUK, and these others are all PSI members. So we conducted the research, and this is what we find out. I will share the link in the chat box so that people can have a look at it. So what we suggest, and this is exactly what is going on here in Australia, even in our facility. So we are trying to do, if you call, like a return of unused medication. So it's like this is like a concept whereby a patient or a customer is asked or is required to bring any unused medication or expired medication at home. So you bring it to the pharmacy. In the pharmacy, you have like a dedicated like packaging. So when you bring it, we put it in a nylon labeled return of unused medication. So you put it in a particular safe disposable box. So at the end, I think the minister, it was the minister in charge of the environment, normally went around pharmacies and collect them. And in Tasmania is the council, like local government council. So like the council, they are the one in charge of disposing all this rubbish from homes and from factories. So they now come, they have different box. This is box for medication, box for all these injectables, and another box for normal recycle, and the other one for normal rubbish. So it's something that we have done. We have done the first phase, and then we are now planning the second phase. As you rightly mentioned in one of your presentation, this is something that will need funding. So that is what we are thinking around, how we can source funding to commence the next phase of the research. So Samira, yes, there is something on it. And in the second phase of the research, I'm very sure, like what Dr. Araka mentioned, it will definitely involve collaboration. And sir, you may see our collaborating later very soon. And thank you so much.
That's fine.
All right.
All right. Thank you, Mr. President, for sharing that. For those that want to see a lot more of PSI research, we shared our website. You're going to see a compendium of PSI research there, and a lot of publications are there. So another question for Timothy, it says, what is the role of independent prescribers in oncology and palliative care? Then another one is HbA1c, part of the blood test done for patients, for your patients. And okay, there's an initial question to Prof. Etimora, and I will allow Timothy to finish his one, then later I will ask Prof to respond also.
Okay, thank you. Yeah, so in the oncology and palliative care, especially oncology, is strictly managed in secondary care. When I mean secondary care is the main hospital. So that's where all our specialists are. That's where all our oncologists are. And in those hospitals, they have pharmacists as well, hospital pharmacists that work there. And the push also is for a lot of them to become independent prescribers. And why this helps is when they are going on ward rounds with their oncologists, or they are viewing patient medication records together with the consultants, they can make reviews and make changes because of their expertise. The key thing with the independent prescribing is, in the past, even if they wanted to make changes, they couldn't, because they have to then pass it through to the consultant. But being independent prescribers and specialists in that area, so when you're doing your course to be an independent prescriber, you have to choose an area. So those people who choose oncology as their area of expertise. So the expectation is that they are competent in that area. And what happens is, if they're doing a review and they notice something that needs to be changed, instead of having to pass it through their consultant, they can, if they feel they should discuss it first, but they can actually make those changes as independent prescribers. They can sign the prescriptions and give it to the patient or the patient representatives to go to the pharmacy and collect things like that. So that's the role they play. Even in palliative care is a big thing here, because it's linked with oncology. A lot of people, once if you've got cancer and unfortunately you get to the stage where it's palliative, you're shifted to the palliative specialists, palliative care specialists or consultants. They have specialist pharmacists there as well. So and with that, in that area, we have palliative drugs or meds to make you comfortable, because we know it's probably not, things are not going to improve. So the pharmacist there and then can create those, as an independent prescriber, can create those drug charts, whereby before he wouldn't have been able. It was only the doctors or the consultants that could create a drug chart for the nurses to give the regular morphine or in the syringe driver or things like that. So you, as an independent prescriber, competent in palliative medicine, will be able to create those drug charts. You'll be able to sign them off, and the nurses, the palliative nurses, will be able to administer those drugs with your signature on it, because you're now a prescriber in that field. So in every area, it's not just oncology, palliative care. In the rheumatology, you have pediatric pharmacists that are independent prescribers. So it's about you finding that niche and then being confident in that niche to actually prescribe in that area. You can prescribe everything. Independent prescriber, I can prescribe anything I want, but for clinical governance sake, it's always good to have an area of competence where you know your stuff. You've read, you've done your research on that, in that area. HbA1c, yes, it's very key. It's a very key marker for our diabetes patients here in the UK. We do it every 3 months. Is what we use to measure how patients' diabetes is actually under control, and it also gives us a guide. Once it goes beyond 80, we then refer them to the diabetes specialist nurses who have got a bit more expertise than us. So it's a very important blood test. It's done every 3 months. If it's high, we can request it to be repeated in 3 months. Print the blood forms for it to be done, and it comes back to us. So it's key for us as clinical pharmacists, the HbA1c, when managing our patients who have long-term conditions like diabetes. Was that all?
Yes, then we have some few more before you go.
Okay.
This one says, what is the role of medication therapy management in patient care researches in Nigeria? This is one of the important roles for pharmacists. This is also for you, though it's asking you for this in the context of Nigeria. So I don't know. The next question is, how do you deal with fixed those combination mix in your medication review?
Okay, so the first question that is related to Nigeria.
Yeah, what is the role of the medication therapy management in patient care and researches in Nigeria? This is one of the, I think the question is asking.
Was it for Professor Mora or for me?
It was addressed to you actually. Maybe Prof or Dr. Danraka can actually say something. I'm reserving questions for Prof. I believe he can be able to say, because I've seen a lot of regulatory questions. Okay. Then I think you can just answer the one of fix those combination meds.
Okay, that's fine. So fix those combination meds is something that we deal with for some reason. In the UK, I don't know, we have quite a lot of people that come from the European. Before we left the EU, we had a lot of EU patients, and is very common in other parts of Europe where we have loads of fix dose combination meds. For some reason in the UK, we have less, and most of our protocols, we tend to use less of fixed dose combination meds. Probably maybe because it helps us to then it gives us a very difficult room to kind of, we have to stop the whole treatment, you know, to kind of get rid of. So it's not common meds. Like there are some people on them, but not a lot. So, but once if you come across them in the repeats, during our reviews, it's the same way we deal with those on individual meds. But like I said, majority of our patients are on individual meds because it helps us during our reviews when it comes to dose optimization, or if they are having reactions and we want to stop one and continue the other one instead of having to stop all and then restarting individual meds. So that's what I would say regarding fix those meds. Was that the other one? Is that all?
Yeah, that was the second question. I think we'll let you rest for now, then I'll go back to Prof for now. All right. Hello, sir. Hello, Prof. We have questions for you, Prof.
Okay, can you hear me now?
Oh, yes, I can hear you, sir. There are two questions.
Yes, sir, loud and clear.
Okay, thank you.
Right. So one of the questions is, how can the council drive the advocacy of task shifting by NPHCDA to develop task shifting of including community pharmacies in Nigeria to play in the network of primary healthcare service delivery?
Very good. This is a very good question. Yeah, and let me answer that question, please, because this is in the front burner of what the Pharmacy Council intends to do. We have had webinar meeting with the Executive Secretary of the National Primary Healthcare Development Agency. That was last year, but he was so busy with the COVID monitoring and so on. But he he delegated the Director of Research and Statistics, and we had this collaboration. And then what I've always had in the back of my mind is the fact that I sincerely believe, and I'm sure pharmacist Kujiyat talk about it, I sincerely believe in the referral system from the primary healthcare to secondary healthcare to tertiary healthcare. I'm sure Basira Lorokanki is listening to me. When I was dean in Kasu, we did a research study with Ismail on this aspect of a referral system. Now, when we had the COVID, we discovered a gap in the sense that the community pharmacies were not actually contributing towards the components of, say, immunization and other things. And certain group started some kind of courses on immunization, teaching the community pharmacists to immunize subjects and so on, which I take strong objectives to, because of the fact that it is not in our curriculum. And the license that is given to us does not include introduction of hypodermic syringes to the tissues. So what I wanted to do with the National Primary Health Care Development Agency was to have the totality of the components of responsibilities of primary health care. Primary health care services allocated to community pharmacies. How do I mean? You look at the secondary healthcare facilities, provider facilities. You have the equivalent in the private sector, but private, that is in terms of private clinic. You have the tertiary teaching hospital. You have the equivalent, you have both tertiary, that is public in the teaching hospitals and the public medical center and the medical centers. You also have the private in, like, say, Igbinedo University Teaching Hospital or Afiba Bolala University Teaching Hospital. But when you come down to the community pharmacy, you don't have the private sector equivalent. You only have the primary healthcare centers, which are run by the local governments. You don't have the private sector equivalent to it. So the conversation is that the totality of the components of the responsibility of the primary healthcare, of the community pharma, of the primary healthcare should be allotted to community pharmacies. In other words, community pharmacies should be given primary health center status, so that they can now dispense these services beyond immunization. It's not immunization, is just one component. So that is what we're working towards now. And we are engaging the National Primary Health Care Development Agency towards that direction. I hope that answers your question.
Thank you
very
so
much,
much.
Prof.
Yes.
Very
Thank you,
much,
sir.
Prof. Thank you, Prof.
Thank you.
There's a second
The
question,
next one.
sir.
Yes.
All right, sir. This one gave a background before asking the question. He said, I think pharmacists have a very low representation in the primary healthcare service in Nigeria. Community pharmacists are disabled with large number of patients with long-term conditions. Though we try to manage these conditions, we are often faced with incessant regulatory restrictions. How can pharmacists in Nigeria work their way to a license to manage these conditions?
Yes, actually, this goes along with the first question that I attempted to address. Now, listen, these things are policy driven. You cannot just wake up one day as let's say some ACPN persons are trying to do and say, okay, we want to start giving people injections, intravenous, intradermal, and so on. The national, because we will have problem with the Medical and Dental Council, we'll have problem with the Nursing and Midwifery Council. These professionals that are responsible for administering medication. Just like if Medical Life Science Council in Nigeria, just for instance, start to manufacture pharmaceutical products, we'll say no. That is the issue. So we want to take it in a systematic manner. That is, have a memorandum to the National Council on Health to address what I said earlier on, that the totality of the components of the primary health care should be allotted to community pharmacists. The community pharmacists in Nigeria should now be given the status of privately owned primary healthcare provider facilities. Now we take it from there. Now let's see, from 400 level in the universities, we now start to teach the students the use of hypodermic syringes in introducing medicaments, parenteral preparations from the vials, from the ampoules into the tissues. And this doesn't take 2 or 3 days, because you really have to train them very well on that. And then coming to the regulator, the license will also indicate such that you are now allowed to also administer parenterally. This is not in our license. So if anybody goes ahead to now administer parenterally and there's an abscess or something happens to the patient, if the patient is really enlightened, I mean, he can sue the pharmacist who has done that, because we are not as at now licensed to administer parental preparations. But we're going towards that direction. Other aspects which has to do with oral rehabilitation therapy, testing for malaria, testing for other things, are all components of the primary health care, which we want to take a whole scale of it. The total gamut of it should now be transferred to the community pharmacies. So that, but then it's a policy-driven thing, which the National Council on Health has to now approve. Once that approval is given, fine. Then we now have multiplicity of advocacies and capacity building to now teach, the competencies in respect of this to the community pharmacies that are in practice, and then also entrench it in the curricula to those that are actually in the universities. This is the way we ought to approach it. Thank you.
Thank you so much, sir. Thank you so much for that. I would now like to give chance to voice questions. David Funshaw from Funshaw, please, you have the floor. You can ask your question.
Thank you very much, Pharm Shaban. Good evening, everyone. It's evening here in Nigeria. Good evening, good evening, Prof. Etimora and the other professors on the call. Thank you to the organizers of this educative webinar. I think it's been a very good one. The time is fast spent, so I'll just quickly go to my question, and it's for Prof. Etimora. This is a little bit of policy and regulatory related, right? I came across your thoughts, your presentation on the new Pharmacy Council of Nigeria Law or Act of 2022 that repealed the Pharmacists Council of Nigerian Act of 2004. And my question is, in this new law or act, is there any focus on incorporating pharmaceutical researchers to the training curriculum of our first degree Bachelor of Pharmacy? If there is, can you please just educate us on this and maybe ways to then implement it in the curriculum? Thank you, Prof.
Thank you very much. For sure, let me say this. I'm sure you are aware the National Universities Commission, actually, which is the regulatory body in Nigeria responsible for university education program, has come out with a position that addresses the issue of all the curriculum in science-based curriculum. And it appears that the pharmacy, that of pharmacy, B-Pharm and PharmD, seems to have been a little bit, with all due respect, modular. In fact, tomorrow, from 2 p.m., I'm having a webinar meeting with the deans of the faculties of pharmacy in Nigeria, because my capacity as the chairman of the council, I'm also the chairman of the education committee, to look at this issue. Because, for instance, it's been said that pharmaceutical chemistry has been removed from pharmacy and taken to the faculty of sciences and so on. So these are issues that we're going to look at, but that's just by the way. Now, to answer your question, the issue of the Pharmacy Council law, which was signed into law, the bill which was signed into law by Mr. President on the 16th of August 2022, is a very good development as far as pharmacy is concerned. And quickly, I can say, you can see the name from Pharmacist Council. We're now going to Pharmacy Council, which addresses the profession. And this is the first time that we're having this, because we're having some challenges with the pharmacy technicians that want to actually make some incursion into the pharmacy profession, and we're even advocating for their own board, which would not be good for the pharmacy profession. Now, significantly, what actually the Pharmacy Council law addresses, to put it broadly speaking, the fact that we now have pharmacy technicians as members of the Pharmacy Council, 3 of them. We now have the DG of NAFDAC as being a member. We now have the registrar of the council, Pharmacy Council, as a member and secretary. Hitherto, the registrar is only a member. It's only a secretary. It's only the secretary. It's now a member. So, but specifically in terms of education, because the law addresses the issue of what we do, regulating and controlling pharmacy education and training as well as practice. It addresses the issue of the fact that there has to be a robust curriculum which will now expose the pharmacy students towards giving his or her best for the advancement of pharmacy education pharmacy practice in Nigeria in collaboration with core healthcare professionals. So that is an omnibus. It's an omnibus clause which presupposes that naturally the component of research must be addressed. I was in Igbilede University just last week. I teach there actually, and I'm taking courses on research for the students. Just like all other universities must address component of research, because the students have to produce, have to prepare their own projects, and they are given what do I say, their own supervisors. So specifically to answer your question, yes, the new Pharmacy Council law addresses that effect, because it makes it whole scale, to the effect that the pharmacy student should not just be, I cannot tell you the section, should not just be limited in its scope to practice alone, but in research. That's why we really believe that the B Pharm is equally as good as the Pharm D, because the foundation of the B Pharm is very good and very rich in terms of the component of sciences, which leads to research. Thank you.
Thank you very much, Prof.
Thank you.
It's okay, like, right, Jato, you want to say something?
Yes, sir. I just want to ask a question to you, and it's a singular question, but it's to you and Timothy. It's like from the presentation, Pharmacy Timothy clearly mentioned that independent prescriber is new, like in the whole world, like, yeah, in the pharmacy profession. And like UK is taking the lead in terms of this. And I even added that some states in Australia have started doing it. But when he goes in detail into his lecture, I just realized, though I just did some local pharmacy while in Nigeria, and I did my NYC there. I just realized most of what he's saying is actually practiced in Nigeria in the community pharmacies.
Yeah, it is.
So like the prescribing, the counseling, I'm not too sure about the test. So I'm a bit not confused. It was the law, PCN law actually allowed community pharmacy in Nigeria to prescribe, to test, like what Timothy said, because he says it's new. And in Nigeria, I think for past years, this has been in existence in our community pharmacy. So are community pharmacy actually allowed to do that based on pharmacy law, like to prescribe any kind of, because they prescribe any kind of medicines? They're like the scheduled medicines, the Schedules 8, Schedule 4, I think, yes, in Nigeria. So are we allowed, like community pharmacy in Nigeria, to prescribe like antibiotics, controlled drugs? Because they do. Does the law support it, or I don't know?
So we're still up there. We're still where we were when you left this country, you know, but let me address the issue. Of course, you have the over-the-counter products, which you don't have any prescription. And you don't need any prescription to issue out. I wouldn't even say this, counsel the patient, because everybody knows about it. But the issue is this: there are certain categories of drugs that have been ethical preparations. Drugs cannot continuously and forever remain ethical preparations. They migrate to become over-the-counter over time because of use. Once a drug assumes the culture or tradition of the fact that almost everybody is familiar with the side effects, with the contraindications and the dosing, then it's assumed that it can now migrate downwards to be an over-the-counter product. For instance, I can see that tetracyclines, which are even though rarely used now, and ampicillins, these are antibiotics that almost everybody can say precisely what are the contraindications, what are these, you shouldn't take this and that, and so on. And besides, mark you, most patients or users of pharmaceutical products now would have Googled the particular product before entering into any pharmacy to find out whether the pharmacist will actually counsel the patient very well. And I keep telling the students, if you want to dispense, if you want to prescribe, you better prescribe very well. Because you cannot prescribe, if you prescribe without the necessary counseling the patient, and then something happens, you'll be liable. So there are certain categories of precision only. That category, we're still working on it. We have to liaise with the medical and dental council to have their buy-in. Once that is done, I don't think we have made much progress in that area, but there is such categories of drugs that would, like, for instance, the ampicillin that I mentioned, the tetracyclines, for instance, that actually pharmacist prescription only. In other words, the pharmacist can prescribe and dispense in his pharmacy. But then I keep on with the caveat. You want to dispense, you have to dispense. You want to prescribe and dispense, you have to prescribe and dispense very well. In otherwise, you cannot give what you don't have. So the component of accessing the necessary modules of mandatory continuing professional development, MCPD, comes into play. If you just close your eyes and start prescribing without necessary knowledge, and then the patient suffers some challenges, then you'll be liable. So that's just, I don't know whether I've answered your question or I'm considering confusing you the more.
Yes,
but,
no, sir, I'm clear now.
that's the position now.
Okay,
that's
sir.
The position.
All right, sir. Thank you so much.
Thank you so much, Prof.
Thank you. Any other question?
So we have additional questions. I just want us to be wary of time. Okay, sir, let me give you the last one.
Okay.
No, sir. This one is asking why Nigerian universities are not admitting pharmacy technicians into level 2, into 200 level. This comes from
They are. They are now. They are. We have the Pharmacy Council actually has worked on the curriculum for the pharmacy technicians, and it has been reviewed upwards in such a way that those pharmacy technicians with the requisite qualifications for entry into university, entry into universities has its own limitations, because you must have at least 5 credit in 5 subjects, including English and the use of mathematics. But the entry into schools for health technologies is not that, the requirements are not that stringent. With 2 or 3 credits, you can enter schools for health technologies. But now it's the responsibility of the student or the graduate of the school for health technology with the pharmacy technician certificate to update his credits in not more than 2 sittings outside, whether during his studentship is in School of Health Technology or College of Health Technology or afterwards. Once he has the 5 credits, he can now be admitted into 200 level. That is being done actually. But then, the clearinghouse for admission into university is JAM, and JAM has been set on that, and there is that understanding they can. But then the only problem is that the admission quota is limited. It's very, very limited. I mean, for universities, but that is being done in other universities, in some universities.
All right, sir. Thank you so much, sir, for clarifying.
Thank you. Yeah.
All right. So I have a few more questions. I just wanted to reiterate the issue of time. We wanted to finish this program by 3:25. Maybe we'll just try to make it to 3:30 Nigerian time, because of the need for us to go and watch maybe the final. So this one goes to Dr. Danraka. Please, what is the current progress in new pharmaceutical products development in Nigeria? I learned that NIPRID, in collaboration with industrial pharmacies, developed some new herbal products. The second question is, how efficient or effective is the residency in drug production and pharmaceutical quality systems? Looking to accessibility to pharmaceutical industry. Dr. Danraka, these questions are for you.
Okay, thank you very much. The first question on the issue of herbal preparations, even though I'm not in this presentation on behalf of the Institute, but it's good to report that from the informations made. Thank you very much. I hope I am audible.
Yes, yes.
Yes.
Thank you. I said the first question on herbal products, I made a caveat that even though I'm not in this platform on behalf of the Institute, but I'm aware the information being given now is made available through different fora by the DG of NIPRID. Yes, the R&D endeavors in the institute are ongoing, and we have a stream of products that are being developed, both by our R&D team and also very few in collaboration with some researchers outside the institute. So I will say that we have a lot of products developed for many disease conditions that are undertaking clinical trial. Because of funding challenge, they have not progressed beyond that, but they have been duly patented and trademarked. About 5 of them have been duly registered by NAFDAC, and they are available for uptake from the institute. That is that for that. Then the second question on how efficient is the residency training of the West African Postgraduate College with respect to Faculty of Drug Production and Quality Assurance. It's to the limit of how I will respond to that. I know I'm a preceptor of a lot of my resident students. Some are actually in the institute and others are in the 2 available pharmaceutical companies in Abuja. It is good to say that in Abuja FCT, we have 2 functional pharmaceutical manufacturing companies, one in Kujiyat, the other one in Kubwa. They are actually taking relevant students that want to know how productions are done. They are doing basic liquid production and tablet production. So I could say the efficiency is there, but what is lacking or the challenge is the commitment of the resident, that is the student. I always use this opportunity when I get that majority of our postgraduate students want to do what is cheaper or easier for them. But I always disabuse their mind that postgraduate studies is not about what is easier for you, it's about building capacity. If you are coming to the West African Postgraduate College, you should come with the mindset of improving your capacity. So the whole idea of no matter how rigorous the residency might be, I think it's just a time-bound thing that once you assert yourself, as we did, I underwent my residency training in NIPRID. I went to as far as Niger State, the Dana Pharmaceutical, to learn the basic aspects of drug production according to their production line. So it's not easy, but at least once you develop yourself, the benefits come with that expertise and competence. Thank you.
Thank you so much, sir. Because of time, we are sorry we may not be able to ask all the questions. I have a few announcements. We would like to recognize the presence of Dr. and Professor Sani Malemi, who is the current Dean Faculty of Pharmaceutical Sciences, Bio University Kano, and also the chairman of NAPA, Professor Akinkubi. Thank you, sirs, for joining us. Without much waste of time, I would like to invite Dr. Abubakar Shaban to give us the closing remark. But before then, sirs, for the presenters, we have a token of appreciation as per certificates of service to us, which will be forwarded to your emails. We really appreciate your time and the input you've made into seeing our program become a success. Thank you so much. So, Dr. Abubakar Shaban, please let us have the closing remarks.
Okay. Yeah, thank you very much for giving me this opportunity, Dr. Abubakar Isa Musa. Yeah, before we share the certificates through the email, I think I'll use this opportunity, to just, because it's virtual, though it's virtual, but at least let's share the certificates so that everyone can see. I'll use this opportunity to first of all thank Prof. Ahmed Tijani Mora for his outstanding contribution as the chairman of the occasion at this 5th anniversary workshop. Thank you very much, Prof. We are highly grateful. Despite your tight schedules, you spare your time, your weekend, and everything to be with us from the beginning until the end. We truly appreciate.
Thank you, Abubakar. Thank you very much. My pleasure.
Yeah. And then secondly, I'll also wish to thank Dr. Abubakar Danraka for his outstanding contribution as a guest speaker on this very wonderful occasion of our 5th anniversary webinar. Thank you very much, Dr. Abubakar Danraka.
Thank you very much. The pleasure is all mine. Thank you.
Yeah. And then last but not least, wish to thank Pharmacist Kujiyat Timothy for his outstanding contribution also as a guest speaker at the 5th anniversary. Thank you very much for sharing your experiences and advances in what is happening. Thank you very much.
Thank you so much. I'm very grateful. Yeah. And can we have slides, especially Dr. Danraka's, if possible?
Yeah, definitely. Ibrahim, please, can you check the person, someone, if you can mute the person?
Yes, I'm trying to get the person, but
okay. Okay, I think the person has muted himself. That's grateful.
Yes. Yeah. Are you done?
No. Okay. So I'm delighted to close this session by thanking you all for attending this 5th anniversary webinar for 2022 of the Pharmacy Scholars Initiative on the theme Bridging Pharmaceutical Research Outcomes to Impactful Government Policies in Low and Middle Income Countries, holding this day, 18th December 2022. The chairman of the occasion, Prof. Ahmed Tijani Mora and Dr. Danraka Abubakar, has done justice. They have done justice to the theme, while Timothy Kujiyat added flavor to the webinar by showing the diversity of pharmacists and the pharmacy profession. We are indeed grateful to all the to both the chairman and the speakers at this great occasion. Also use this opportunity to thank I think one of my hosts in Malaysia, Mr. Nazrul Rizwan bin Muhammad Nazri has been with us. Yeah, he's not a pharmacist, but he's happily married to a pharmacist, which is also a researcher. And then with the passion he has for the profession and support, he has been with us throughout the occasion. Thank you, Mr. Nazri. Also, the chairman, national chairman of NAPA, Dr. Akinwumi Olubenga, we thank you for being with us. You also thank Professor Abdullahi Abba, the Provost, College of Medicine, Kaduna State University. Thank you, sir, for being with us. And also Prof. Sani Malami, I also realize he's here, and all other dignitaries and all other members that have been with us. And most especially, each and every participant that has been with us from the beginning until this moment, because without you, the participants, then the webinar is meaningless. So thank you very much for sparing your time to be with us at this August gathering. We truly appreciate, and we hope the information and knowledge learned will be put to use. It will be beneficial to both you, humanity, and profession at large. Thank you very much. Thank you.
I'm sorry for chipping in. Before closing, Mr. Moderator, I just want to make an announcement. We have a certificate to every participant. So every participant, we are giving him a certificate of participation. So please, I just shared a link. The link is just to have your name and your email. So we can use the email to send you the certificate, the recording, and the lecture notes of Pharmacy Timothy, Dr. Danraka, and Professor A.T. Mora. So please just use some few minutes to drop your name, your email address, and yeah, that's all. And you just write the name as you want it to be on the certificate. And we are going to compile the names and send you the certificate, link of the webinar recording, and the slides for the webinar so that you can go through at your own pace. Thank you so much, and see you next in 2023 for our webinars. Moderator, over to you.
Thank you, everyone. We've come to the end of this webinar, and like you said, you can check our website for all details. So please have a nice time, stay safe. Goodbye. Thank you.
All right. Thank you so much, everyone. Bye-bye. And good morning
Thank
from
you,
here.
everyone.
Bye,
guys.
Bye-bye.
Good afternoon from here.
Good morning.
Thank you, colleagues. Thank you, friends. Thank you, everyone.
Thank you, everyone. Bye-bye.